Good afternoon, ladies and gentlemen. I'm Dr. Silva, and today I'm going to be talking about Remeron, or Mirtazepine. Remeron, the almost perfect antidepressant. Remeron is almost perfect as an antidepressant, except for one thing, and I'll get to that in a second. But first, I want to tell you about Mirtazepine. It is different than the SSRIs, the Prozacs and the Zolofts and the Lexapros, which are probably the most commonly prescribed antidepressants. So Mirtazepine is different from the SSRIs, first of all, because it increases not only serotonin, but also norepinephrine. So in that regard, it's closer to the SNRIs, the serotonin norepinephrine reuptake inhibitors, than the selective serotonin reuptake inhibitors, just in terms of the neurotransmitters that it increases. And when you increase serotonin, you soothe an agitated depression. So not only do you get a sense of well-being and a sense that everything's going to be okay, but you have reduced anxiety, you have reduced irritability, you have an improved frustration tolerance, decreased irritability. So that's what serotonin is good for. What norepinephrine is good for, noradrenaline, is it increases energy level, it increases alertness and desire. It treats anhedonia, which is that not feeling like doing anything, which can actually be a side effect of too much serotonin. So it's a nice balance. And for those patients that don't want to get out of bed and that are having trouble concentrating and that have a low sex drive, which is another thing that SSRIs can worsen or cause, you want norepinephrine. So sometimes for some patients, it's a plus to have that dual mechanism of action. Venlafaxine was the first SNRI that was developed, and then Cymbalta. But those medications, the SSRIs and the SNRIs, all work by the same type of mechanism, which is blocking the reuptake of those neurotransmitters. And just in a nutshell, one way that neurotransmitters get cleared away from the synapse and that their actions are terminated is through reuptake, so that the neuron that released it takes it back up again, and that terminates the action. Well, if you want more action, if you want to increase the availability and the actions of serotonin and norepinephrine, then one way to do that is to block that particular mechanism, one of several, for terminating the action of those neurotransmitters. That's what SSRIs do. That's what SNRIs do. Prozac, Zoloft, Paxil, Lexapro, Luvox, Celexa, Effexor, and Cymbalta. And there are some other multimodal ones, but those are the core ones that are SSRIs and SNRIs. So Mirtazepine is neither an SSRI nor an SNRI. It doesn't work through blocking reuptake inhibition at all. So Mirtazepine, Remeron, is not a reuptake inhibitor. It increases both serotonin and norepinephrine through unique mechanisms of action, which makes it a great medication to combine with other antidepressants when you need to do that, when you need more than one antidepressant because a patient's not responding to monotherapy. Remeron's a great choice, one of the things that makes it an almost perfect antidepressant, because when you combine it with other antidepressants, you avoid redundancy. You're actually adding unique mechanisms of action to, say, reuptake inhibition in order to further increase serotonin and norepinephrine. And therefore, you get a synergistic action, not just an additive action, but a synergistic one. So how does it increase serotonin and norepinephrine? It is a serotonin and norepinephrine receptor antagonist. It blocks certain serotonin and norepinephrine receptor subtypes. And the important ones for efficacy are the presynaptic alpha-2 receptors. So there's a presynaptic alpha-2 serotonin receptor, as well as norepinephrine receptor. And I'm not going to get into the specific pharmacodynamics of it. It's not that important. It's important, but not for the purposes of this talk. But by blocking those receptors presynaptically, you get an increase in both serotonin and norepinephrine. But Remeron also blocks 3 types of serotonin receptor subtypes, and that makes it responsible for the side effects from this medication, as well as blocking histamine. Remeron has a significant antihistaminergic effect, so it can be considered a prescription antihistamine, which is responsible for one of its main side effects, sedation. Now, this is a plus. This is not a bad thing because we give it at night and it is a great sleeping pill. Even better than trazodone. It's much more effective at sleep because it makes people very sleepy, and it does so in a non-habit forming way. That's also, because it's tied into an antidepressant, not unlike trazodone, good for the mood. You can take it long-term, and there's no concerns about long-term use of mirtazepine as a hypnotic agent. Now, you can get a little groggy the first time you take mirtazapine. It can be a little strong, and so a lot of times there's a antihistaminergic hangover the next day. It gets better, and as a patient develops tolerance to that side effect, which does happen over time, they still fall asleep okay, but they just don't have the carryover effect so much the next day. We used to think that the lower doses of mirtazapine were actually more sedating than the higher doses, but that's not true. That's been debunked. The deal is that at the lower doses is when people don't yet have tolerance to the sedative effect of the H1 blockade that Remeron induces. And so at the beginning, it's very sedating. And then as we increase the dosage, they appear to get less of this sedating hangover effect, but it's because they're developing tolerance. And so if you go slowly, you don't see an escalation of the sedative effect every time you escalate the dosage, the way you might with habit-forming sedatives, at least initially. You develop tolerance to those medications as well. But with mirtazapine, you got to start slow, and especially in the elderly, and be patient, and that effect does get better. It's really, going to sleep is great. It's just waking up in the morning can be a little challenging. And for a minority, a subset of patients, that can actually last more than just a few days, and it can be a bit of a challenge. But if you're patient, most patients do overcome it in time. Mirtazapine also has the huge bonus of having no sexual dysfunction. Sexual dysfunction is common with virtually all serotonergic antidepressants except for mirtazapine. Mirtazapine doesn't have those effects even though it increases serotonin. Because it happens to block the 5-HT serotonin, it's 5-hydroxytryptophan, that's serotonin, 5-HT for short. Not only does mirtazapine not cause sexual dysfunction, but it actually reverses the anorgasmia caused by other serotonergic antidepressants, again, making it a fantastic medication to combine with those agents. And this is because mirtazapine blocks the 5-HT, 5-hydroxytryptophan, serotonin, 2A receptor subtype. And it's the extra serotonin induced by those antidepressants that increase serotonin at that receptor, stimulating that receptor, that lowers the libido and blocks the orgasm. It makes climaxing more difficult, it makes it take longer, and it makes it less satisfying, and sometimes it blocks it altogether. And so if we can then in turn block that receptor, then even though we have all this extra serotonin floating around, it can't attach to that receptor with the same frequency, and thereby we can either obviate that side effect or reverse it. And so that makes mirtazapine a fantastic agent to add on specifically for that purpose. So there you have 3 fantastic reasons to use mirtazapine either by itself or in combination with other antidepressants. It doesn't cause sexual dysfunction. It has unique mechanisms of action that avoid redundancy when combined with other agents, and it's a great sleep aid, non-habit-forming sleep aid. Another bonus with mirtazapine is that it blocks the 5-HT3 receptor subtype. This is the same receptor subtype that's blocked by the antiemetic drug ondansetron, Zofran, which is given to cancer patients undergoing chemotherapy, as well as for anesthesia postoperatively. Those are conditions where nausea can be very intense. Ondansetron is a very effective antiemetic, better than Phenergan and better than some of the other ones that have been used previously. And Zofran works by blocking the serotonin 3 receptor subtype, just like mirtazapine. Mirtazapine has that built in. You can consider mirtazapine and Zofran to be the same medication. Mirtazapine is Zofran plus. And so what's the benefit of that? Well, you don't get any nausea with Remeron the way you do with the SSRIs. The SSRIs that are notorious for nausea and sexual dysfunction, and here you have a medication that doesn't cause either and that can actually reverse both. And so if you have a patient who's particularly sensitive to being queasy and who can't take medications because they have a very sensitive stomach, mirtazapine is an excellent choice by itself or in combination. Mirtazapine is approved by the FDA for the treatment of major depression, and it's a great antidepressant. I have a sense that it's not quite as good an anti-anxiety agent than the SSRIs. If I have somebody who's really agitated, really needs to calm down, I tend to gravitate toward the SSRIs, and then if we need to add a little Wellbutrin for the loss of libido or a little bit of mirtazapine to help bring back the orgasm, then we can often make those combinations, particularly if the patient is not sleeping well at night. So What's the catch? Why don't we just prescribe it all the time? We have a perfect antidepressant. It can be taken at night once a day. It doubles as a non-habit forming sleep aid. It doesn't cause sexual dysfunction. It doesn't have nausea. It doesn't have the GI side effects that other antidepressants do. Why not prescribe Remeron all the time? The reason is because it also blocks 5-HT2C receptors. And that serotonin receptor subtype, when it's blocked, causes a ravenous appetite, the munchies. People have a huge appetite on mirtazepine, probably also exacerbated by the fact that it blocks histamine H1 receptors. So those two receptors that are blocked, probably there's a synergistic effect, because in my opinion, far and away, mirtazepine has the worst weight gain of the antidepressants. The only medications that I can think of off the top of my head that are worse in terms of weight gain are Zyprexa and Clozaril, and those are antipsychotic / mood stabilizers. They're in a completely different class. Other than those two, mirtazepine is the worst one. It's worse than Paxil, it's worse than Lexapro, and it's a real problem. Now, do all patients gain weight? No, but the vast majority do. Almost all patients either gain a little bit of weight or they have to stop taking the medication because they are gaining weight. And so it's no reason not to try the medication. We can always do an about face. If 5 pounds later, we can stop and the effect reverses. But if we're not careful, I've seen people gain 60, 70, 80 pounds over a period of several weeks. And it's through increased appetite. It doesn't change the metabolism. It causes somebody to be ravenously hungry. And it's a real problem. Now, it's not always a problem, right? If we have somebody who is cachectic, who is wasting away, HIV patient or a cancer patient who's also going to be probably nauseated from the chemo, Remeron is a great antidepressant for cancer patients, for HIV positive patients with AIDS, for the elderly who may also be losing weight, losing muscle mass for whatever reason, depression or other physical reasons. They aren't eating enough, they can't maintain their weight, and so mirtazepine is a real favorite among the elderly. It helps them sleep and it doesn't make them dizzy. You do have to be a little bit careful with that, but if you take very low doses and you go very slowly, you get very nice results in terms of appetite and sleep with the elderly. And they feel better. Their mood improves, their outlook improves, and it's also very successfully used. I've used it a lot in the elderly with dementia, with behavioral disturbances. So there you have it. Mirtazepine, it is a wonderful antidepressant. It would be almost perfect. If it weren't for the weight gain, it would be my go-to antidepressant if we didn't have this weight gain roadblock that is more of a deal breaker for a lot of patients than even a little sexual dysfunction. Remeron also comes in an ODT, an orally disintegrating tablet, so that can be placed on the tongue. Also very useful for the elderly that may have trouble swallowing pills or that may be less than cooperative if they have dementia. And it also bypasses any food that may be in the stomach, so you don't have to necessarily be on an empty stomach to get the hypnotic effect that helps you go to sleep and then the next day wake up in a better mood.